Thanks, everyone. So we're now transitioning. If you have any questions for the presenters, please take a few minutes and ask questions, and we'll get you microphones. Like, we got 3 microphones, and I have at least 5 people on our team, so they're running. And also, I wanted to let you know, after a few minutes with questions about the presentation, we really want to open it up for all of you to talk together, ask questions of each other, ask questions of the panel, ask questions of Dr. Lindstrom, Mika. We know in the work that we're doing that we have a lot of people that are struggling in their communities to get other folks to do it. Some providers want to do it, the providers they work with don't. Or there's all kinds of myths or misconceptions. And so ask any questions if they're not your questions. Maybe it's something about how to talk to somebody else, how to encourage patients and other providers to start doing that. When I hear people that say, well, it takes 3 hours to get to a treatment provider, and I say, well, is there a nurse practitioner or physician assistant? Well, yes, but they don't want to do it. So we're really trying to help problem solve. And I want folks to know one other thing before we finish this. This is being recorded as well as we have slides. It's being recorded so that we're going to break it down and edit it and put it on our website. So if you guys want to sit with your staff or folks in your community and say, hey, I want you to watch this presentation, that you guys will have access to that. We also at the New Mexico Opioid Hub have lots of resources and support. Dr. Bott in particular, every Tuesday at noon, he is available for questions and consultation around medication-assisted treatment as part of our ECHO project. And you're all invited, and everybody else is invited as well. Everybody has emails. Our state is very big, but we don't have that many providers, so I don't think, Snehal, your phone doesn't ring all day long. And I know if I reached out to the other panelists that they would be willing to help as well. So please know we have lots of resources and support. Dr. Whiteson over there is heading down, I hope, to Deming soon, to support some providers there. So you're not alone, and we're here to support you in any way you need. Floor.
Hey, thank you. That was cool. I would like to accept your challenge of getting over my personal bias. If you could explain to me what would be the indication for you if you were interviewing a new patient that would make you recommend naltrexone as the best option for that person versus the other ones?
That's a great question. And is this microphone on? And we might have 3 answers. But where I have encountered that situation clinically the most is where a patient comes and they come to me, they have an opioid use disorder, and we talk about the different treatments that are available, right? All 3 of them equally. And they say, I don't want an opioid because opioids have ruined my life, right? That's their personal preference, not mine. So I say, well, we've got something that's not an opioid. And we could try that. And then if it doesn't work, then we talk about the other things, right? We talk about the difference between medications and addictions, kind of appropriate use and not. There are also some other situations. So some folks in certain types of work cannot take chronic opioids in any form. So certain professional athletes, for example, cannot take methadone or buprenorphine and still do their professional athletics. And so naltrexone is only an option for them. Some folks in law enforcement have these same demands on them. And so there's sometimes career paths that also influence that. Do you have other thoughts?
A couple of other situations where I found naltrexone really useful. But first of all, when we talk about naltrexone for opioid use disorders, really important to recognize that although both the oral and injectable are approved, oral isn't really nearly as evidence-based. What we know is that people just don't stay on the oral, right? So when we talk about naltrexone here, we're going to be talking about the injectable long-acting naltrexone. The other situation where I use it a lot, in fact, someone I use this on today, someone who'd been on methadone, hasn't used in over 10 years, has been gradually tapering down. Now the client is on the last phase, right, down to like 20 milligrams of methadone, ready to stop. But doc, I'm scared. You know, I haven't used, but that's because methadone's been helping me. What happens now when I go off it? So one of the things we're talking about is getting that patient on the injectable long-acting naltrexone, you know, as a safety net while the patient builds up coping skills, right, relapse prevention skills, and when he feels comfortable, we can take that off. Similarly, I've had patients who are like, I haven't used, but I'm moving back to my old hood, right? Like, I know those people who are using, and I need something, right? So that, again, may be a good, so those are a couple of other situations where I found it extremely helpful.
My follow-up question to that is, what happens to someone who's on a long-acting, the naltrexone, or even potentially the long-acting Suboxone? I know there's not a lot of data around that yet, but somebody's on that and they get in a car accident and now they're all messed up and they have this antagonist thing, this long-acting antagonist going. What happens in that situation?
Kind of what are their options for pain control? Right. I got my naltrexone injection a week ago, and now I have a fracture. So it's about non-opioid, in that case, non-opioid analgesics, right? So regional blocks, for example, non-steroidal anti-inflammatories, these membrane stabilizers, or what we call anti-seizure drugs, ketamine, things like this. There are a variety of options. And what's cool about the new Suboxone training, the certification materials, is that it actually addresses that, to try and educate people as much as possible. But I think we can also have a role in educating, especially people that we know that work in the emergency setting and in hospitals, and give them guidance on how to address this. If they're on buprenorphine and let's say that they're going to go in for a surgery, or they have a traumatic experience, right, in a fracture or something like that acutely, what we do know is that fentanyl is the one opioid that can outcompete buprenorphine at that mu-opioid receptor. It can displace it and can be used for opioid analgesia. It's a great question.
I have a question. For the last speaker today, I consider medical marijuana not an illicit drug because people have medical cards for that and it's legal. And I just wondered if you see it as an absolute contraindication to giving Suboxone, or if you see it as part of their treatment plan, because it really is effective in comorbid conditions like PTSD.
Thank you. Are you asking how we look at medical marijuana?
I'll trade you.
Thank you. Thanks so much. How we look at the issue of medical marijuana and treatment in family systems. Really sort of in two perspectives. I respect people who have a medical indication for using marijuana. That's not an issue, and we do not dismiss people for using illicit or licit marijuana in the context of our treatment process. The one thing that we want to think about in that process is the issue of parenting under the influence. And parenting under the influence, whether it's alcohol, marijuana, cocaine, work, money, all has some potential of removing the parent's brain from presence with the baby's brain or the child's brain. And that's really, in some sense, why we think the child development part is so important, because the more we are able to illustrate the capacity of the child's brain to interact with the parent, I think the greater the parent's investment in the child. So we have people who have medical cards. We would like to suggest that there may be other things that they haven't tried that might be useful in the context of that conversation, but it's not a deal breaker.
Thank you.
So first off, I want to thank you guys, as usual. Fantastic presentations across the board. It's good to see you. Dr. Duhigg was one of my mentors when I was in training. Have the utmost respect for him, and so I wanted to preface the audience that no way am I being antagonistic by this question, but I think it's appropriate to bring up. When you had first of all, I was really happy you brought up the National Academy Guidelines, because they only recently came out, so it was good that you guys were on it. When it came to the slides regarding, ultimately in any situation you should continue treatment, and in situations where we have some pretty dangerous medications on board, more so now. In the past it was benzos, but now we're seeing a lot of fentanyl that we're testing, certainly in the clinics I'm involved in. What I want to bring up as kind of a bigger discussion, and the fact that HSD's here because maybe they can help advise, is there's a concern I have with your liability as a physician treating this, because we can try to do what's best practice and evidence-based, but at the same time, how can we kind of minimize risk when you have someone repeatedly positive for fentanyl, let's say, and all that has to happen is a death and a very aggressive attorney come after you. And that's why I kind of balance, and I'm not sure I've implemented protocols with benzos and fentanyls, as you know, in the past, but I still struggle with this. And moving a bit beyond that, treating pregnant women that continually use, all right? Because ultimately you want to do what's best for the patient, but you're really putting your neck out. And I think nationally there needs to be some movement towards protecting clinicians for these very high-risk individuals if you're going to continue treating, so we're not subject to the typical types of legal threat.
It's a great point, and thanks for raising it. And I love kind of planting the seed of if there are policy protections that can protect us in doing the good work, right? Because I hear this too. Sometimes we'll do a Suboxone certification training or just training people on medication-assisted therapy, and I hear a lot of concerns about liability, whether they're founded or not. Whether they're founded or not, the psychology of that fear can be a barrier to people trying the treatment and delivering the treatment in the first place. One thing I do want to clarify, so let's say somebody is on an opioid replacement therapy, and we are consistently finding opioids in their urine, right? So something is not working. We can try dose changes, we can try a change in the agent, and it's a clinical judgment how long we do that, right? How long we continue to treat them with that opioid replacement. But I also did not certainly mean to say that we should just always keep them on opioid replacement if it looks like opioid replacement is not meeting their needs. What we should not do is discharge them from our practice, right? What we should not do is sever the patient-provider relationship. But I've been in situations like that where, in fact, that's another reason why we will talk about, so this opioid replacement just doesn't seem like it's working, and so let's talk about naltrexone, right? And figure out a change in treatment plan and keeping that provider-patient relationship whole.
I want to say thank you, doctors, for your presentations and all your wonderful work first. So I had a question about if it would be helpful to differentiate between medically assisted treatment or opioid treatment programs with the treatment part and see when are they getting the non-pharmacological support, with substance use being, we know how big of other things are impacting it, and we're kind of with our hands tied behind our back without those non-pharmacological. So like Dr. Bott, you mentioned success at your at ASAP, and you said, I forget the number, but I would be real curious, do you know, was non-pharmacological part of that? And can we start differentiating when we describe a program? Is it appropriate to say it's a treatment program, or is it something else when it does or doesn't include the non-pharmacological? Thank you.
I can start, Snehal here, I can start at least taking a stab at this excellent question, right? So first of all, as Dr. Duhigg mentioned, right, and every substance use disorder is different, right? For opioid use disorders, what we know is that the medication is essential for good outcomes, right? So I think we, certainly at our clinic, we start with that idea that if someone has opioid use disorder, we gotta find the right medication for you and the right dose for you and make sure you're able to get it, right? So that's kind of how we start. And we've kind of taken a trauma-based approach. So when patients are coming in, they've got homelessness often, right? They've got transportation problems, they've got maybe many other things. So we're providing a lot of case management, assisting them with how can we remove barriers so you can come and dose. That's what we're doing, right? We're offering them walk-in counseling, like a lot of different basic skills groups that they can go to. But not, and that's what we're doing. And as they sort of stop using, as they kind of stabilize, quote unquote, then that's when we're getting them connected to more of these evidence-based psychotherapies, right? So for example, seeking safety for PTSD, right, or prolonged exposure, or interpersonal therapy, or whatever. Because we're finding that that's where the benefit of those psychosocial treatment really comes in, right, when we're matching them to where the patient is. And then, as they sort of work through some of those underlying grief, trauma issues, right, and then we're kind of trying to transition them more into reintegration, right? So like, more aftercare groups where they're learning about maybe, DVR, maybe, things psychosocial rehabilitation to start getting them, moving them towards this. So there's clearly a role in a comprehensive treatment for psychosocial treatment, but the key becomes how do you match it, right? And I think one of the big reasons it comes up is that when you look at the barriers literature to buprenorphine, lack of psychosocial treatment availability often rises to the top. When I talk to providers, they say, well, I'm not doing it because we don't have psychosocial treatment available. And what I would, I would say, and maybe, and I would love to see what you guys think, what I would say is that that should not be a barrier, right? And what the recent recommendations have suggested is that you offer these, and if the patients say no, then you still provide them the medication, you try to engage them, you do motivational interviewing, and keep reassessing. And so that's sort of the approach that I think is recommended. I don't know if that even begins to answer a really good question. But.
That approach sounds perfect. I think what I'm asking is our language that we use, because we describe them all the same, right? And so that program sounds beautiful. But is that what we call an opioid treatment program if we got 12 of them and we analyzed them? Or are we looking at different things from one opioid treatment program or medically assisted treatment? And so if we don't have the dialogue and use different terminology and start looking at the data, then we're kind of with our eyes blindfolded. It feels like to me, but maybe.
I think your point is really important, and language does make a difference here, right? So we've said a couple times that 90% of people who come off of one of these three medications, has a bad outcome. They relapse, or they die, which means 10% of folks do okay without medications. Now, nobody's cracked the code on who are those people. Why do they do okay when 90% of everybody else does not do okay? And so I agree with you, and we need to be able to differentiate between these. I think, so it's clear, and we're saying this is the standard of care, that if we're going to say that something is evidence-based, that we need to be talking to the patients about one of these three medications and also offering them psychosocial treatments, right? But what is also not okay is to describe any program that does not offer these medications as an abstinence-based treatment. That is language that I'm hoping we can agree that we will just stop using, because that gives the false impression that abstinence, which probably sounds good to everybody, only includes treatment with naltrexone or no medicines and does not include opioid replacement, and that's the wrong message. Can we all agree on doing that? Awesome.
There's a question back here.
Are any of you familiar with the efficacy of auricular detoxification as an adjunct therapy to medication-assisted treatment?
The auricular, so what it's been shown to do is decrease some withdrawal symptoms, and I've never seen anything that suggests that it has any impact on the long-term outcome of substance use disorder treatment.
Same here.
I'm a director of an opioid treatment program, and one of the stigmas that we see is since we're outpatient based, we see patients who need a higher level of care, and we're trying to get them into an inpatient program or residential treatment program, and they're required to detox off of their prescribed medication.
Exactly.
Yes, exactly. I thank you for bringing it up. Sorry, I think all of us agree. That's one of my big frustrations, and I actually think I'm going to go as far out as to say that's absolutely unacceptable and is unethical and medically inappropriate.
And we should use that language. We should use that language when we talk to our government and when we talk to those programs. I think they need that feedback. This is negligence. This is not okay. This is not evidence-based. Yeah, thank you.
I just want to piggyback on something that Dr. Duhigg said earlier. The comparison between someone who's diabetic, being deprived of their metformin, for non-compliance. So if I'm diabetic and I go steal a car and I go to jail, I'm going to be provided with some kind of medication to treat my diabetes. That is not true, in most of the state, with the exception of the MDC program in Bernalillo County, which does an excellent job, by the way. But it's not true in the rest of the state. When our patients with an opioid use disorder become incarcerated, they are deprived of their medication. And that is extremely troublesome to me. And, change is inevitable. And in this state, we're either going to be an agent of change or we're going to be a victim of change, because it's already starting around the country. There are lawsuits in place right now, and there have been rulings that basically say this is cruel and unusual punishment, and that we should be treating people with opioid use disorder during their incarceration. So any thoughts on that, I'd appreciate to hear.
Well, what comes to mind to me is that this is a policy issue and this is a government issue. So there was reference made to the SOTA, right, the State Opioid Treatment Authority, and this is somebody who's really oversees lots of the regulation in the state around opioid treatment programs. There's a role for the SOTA, and then the criminal justice system as a whole is also highly regulated. And I think that this is a place where there can be government encouragement, if you will, and standards about offering these treatments. Because you're right, it's not just, it's not fair. This is a civil rights issue. We can either treat illnesses or we can punish people for illnesses. I've said for a few years to try and make this point, if we really want to be fair, let's have minimum sentencing for out-of-control diabetes, right? That's like blood sugar over 600, like 3 years in prison, right? And again, so we laugh because that's ridiculous, but this is the approach that we're taking. And I think as people involved in healthcare and as people who see the area of treating substance use disorders as important, this is on our radar. I don't think that the majority of the people in this state have any idea that a medication is withheld if somebody is in jail or prison. And so I think that we can also do awareness. We can talk about this on radios, or we can write into our newspapers, or see if they're interested in writing about this. We can call news stations. I just think that there's a lack of awareness, and I think if there's enough public awareness about an injustice, that tends to also apply pressure to our policymakers. That's my thought. Any other?
I would agree completely, right? And we talk about people who are incarcerated as being a particularly vulnerable population, right? So I do, a fair amount of clinical trials, and if I were to do a clinical trial with that population, we would have to go take that extra step to ensure that their choices are respected, right? And that we're doing our due diligence. But here, it doesn't translate into clinical practice, right? We don't offer them any choice, right? We tell them, well, too bad. You're going to withdraw, and therefore you'll buy that one piece of Suboxone that's gotten diverted in for $150 and use it when you can, and then we'll say there is a diversion problem.
Right.
Whereas I would say there is a lack of access to treatment problem.
Right.
And I would just say, in my experience in the juvenile side, in most of the facilities, their medication-assisted treatment stopped, and it's not continued. But I think if we were going on the policy level to think about how to make a big impact, I think the juvenile justice authorities might be more amenable to that discussion. One, because they keep controlled substances in the facility, for example, to treat ADHD, and two, because the possibility of getting kids onto outpatient induction or continuous therapy while they're in could then be transferred in the warm handoff to continue to maintain them. So reduce the risk of juveniles having overdose when they're released, and it also maybe establish a pattern of treatment that can lead to some consistent care.
I just had a question. Some of my patients that are, on pain medicine, pain opioids, and we randomly check them as well, their urine drug screens. You know, once in a while they'll turn up positive for Suboxone. And most of my patients who either, you know, have addiction problems or have been on prescribed opioids, you know, have tried or been on Suboxone. And it seems to me there's a lot of it on the streets. Like a lot of it on the streets. I mean, it seems like they've all, the ones that are experiencing, you know, withdrawals and stuff and that we're considering, you know, on our new program, a lot of them tell me they've been buying it off the streets. So my husband, who's a non-medical person, when I was talking to him about this, and I understand why it's controlled, he's like, well, why do they need a prescription for it then? If it's such a life-saving drug, why don't they have access to it? And I'm wondering how many people that have had overdoses have also had, and I know maybe you can't tell till maybe you get their medical records if this is street-bought Suboxone or if it was prescribed, but I'm wondering if they're seeing opioids mixed with Suboxone or just opioids.
And if I could just ask people to just introduce yourself for a sec, just say your name and maybe where you're from. It'll help us give a little context to the conversation as well.
Amy Weiss, nurse practitioner, Moore Valley.
So buprenorphine is definitely diverted, right? And actually, so part of the reason why any training and an X certification is required, really we can trace it right back to Prohibition and the Harrison Tax Act of 1914. But, so they tried to put regulation in because well-intentioned policymakers at the federal level, what they were afraid of when the Data 2000 rules were first made is they didn't have enough experience, and they said, well, we don't want a buprenorphine epidemic. We don't want to contribute to this. Now, I think we've got 19 years of good experience here, and we can say very confidently there's no buprenorphine epidemic, right? This is a medication literally safer than aspirin, and saves lives. And so it would be great if we could get rid of any of the training requirements and if access was easier. And it's just an interesting phenomenon. So a study showed actually that people who have tried buprenorphine through non-medical sources, right, tried it on the street, actually tend to stay in treatment with buprenorphine when they finally find somebody to prescribe it to them. They stay in treatment longer than people who have not self-selected by experimenting out there in the wild. And so it does happen. It doesn't concern me in the way that diversion of oxycodone and these other full mu opioid agonists that are associated with death concern me. To get to part of your other question, so in those cases of lethal overdose, when buprenorphine is present, in all of those cases except one, there were lots of other respiratory depressants present, right? Heroin, other opiates, alcohol, methamphetamine, which is now killing more people than heroin in the state of New Mexico. Can't figure out why that one person died with just buprenorphine in their system, but this is not a dangerous medicine. But in this case, the policy is still, I think, steeped in stigma, and it just takes the right leaders to change or reverse that. And I think the more of us that talk about it, hopefully the more likely that is to happen.
You know, and one of the things we're seeing is, right, so again, when the laws were created, when the practice guidelines were initially put forth, we did that based on A, our knowledge with methadone, right, and B, because of lack of clinical evidence in this country, at least with buprenorphine, right? But as we've now been doing it, like Dr. Duhigg said, for about 2 decades, we're actually finding out that methadone and buprenorphine have quite different safety profiles, right? And they're quite different. So for example, it's been shown that if you look at we vary with opioid overdoses about respiratory suppression, right? That we stop breathing, that our oxygen saturation drops. Well, the breathing rate actually plateaus out at about 4 milligrams of buprenorphine, right? Even the oxygen saturation reduction, like how much oxygen is in your blood, evens out at not dangerous levels, even at high doses of buprenorphine. You don't get beyond it. So it's a lot safer. So what we're seeing is that the practices are starting to change, right? Best practices, standards of care, what providers are doing are starting to change, but policy hasn't kept up with it. So that's the mismatch I think that we're often seeing.
So I wanted to get your your perspective. I think it was hit on a little bit earlier, but the kind of the quick context is that after several years of treating patients primarily with methadone, and you'll run your PMPs and you'll see these repeat prescribers just giving them, let's say, varying levels to boatload levels of other opiates for their kind of co-occurring chronic pain issue. I got tired of it because my perspective was, not only is this a safety risk, and then if you couple the fact that they were usually negative on drug screens for these opiates, so they weren't taking it, and you can guess what else they were probably doing with it. I got to the point where I'm like, look, after a couple months, there has to be understanding, like, you're in treatment for this dependence, and it's counterproductive to also be getting these opiates from another provider. And I'm wondering if you've encountered that, and if you've enacted similar policies, because ultimately, if you're already receiving one of these full or partial agonists for replacement, you are getting some kind of pain or analgesic effect anyway. So do you also try to push your patients towards non-opiogenic types of pain management and kind of have a limited tolerance, if any, for additional opiates?
Yeah, I'll start off, Snail here. So we see that a lot, right? Much like you at our clinic as well. And to a degree, as every patient's different, but in general, our approach is always we start off with kind of consents, right? That if we're treating you with methadone and you're getting these other opioid agonists, we need to be able to coordinate with that provider. And because they can't see that you're on methadone, the burden is on us, right? Like that's the onus is on us as the OTP physicians to do that due diligence. So we sort of, so I think that becomes sort of a cornerstone. And if they're saying, no, I'm not going to give you consent, you can't coordinate with my doctors, well then maybe methadone is not the right treatment modality for you, right? We can talk about buprenorphine, we can talk about naltrexone, but methadone might just be too risky, right? So I think that's often our starting point. And then we essentially wind up collaborating. We've had patients, very often with severe pain where we kind of co-manage the methadone and the opioids. And there have been other times where, again, it's come down to, it's really the potential risks are outweighing the benefits. We're worried about diversion, right? We're worried about overdose death, and therefore maybe methadone isn't the right, medication for you. So again, the 2 points being, do benefits outweigh the risk or the other way around? And second, you can change the treatment plan, you can change the treatment modality, but you don't abandon the patient. I think those are the two guiding principles.
And the way that I handle it with buprenorphine, so I'm very selective of my words. So is that I say to them, when you fill this prescription for buprenorphine for me, once you do that, you cannot fill a prescription for an opioid or a benzodiazepine from anybody else. And the second part of that sentence is, it does not matter if they write you a prescription. The responsibility is yours not to fill that prescription. So I put the responsibility on the patient. The other thing that I stopped doing is I stopped co-managing, like with benzodiazepines, with another prescriber, because in theory and on paper, it is awesome. We're going to talk every day, right? We're just going to call each other up and talk about our shared patients, and it just doesn't happen, right? Communication is hard with busy people. So my policy now is that I will take over that other prescription. And I will help wean them off of it. Or if they're one of those rare people that need to be continued on it, I want to be in control of both, because I think that patients get lost and or can take advantage of a situation where you have multiple prescribers. And either way, it's not in their best interest. So
Yeah.
I really promote that idea.
And to clarify, with benzodiazepines, that's exactly what we do, and where it's just safer. Totally agree.
Yeah,
So
we have a question.
I really appreciate this discussion about kind of being holistic in treating our patients. And I want to circle back to the point I made earlier that can be broadened, where I talked about, well, why is there all this extensive training to help people get off opioids when there's no training at all to get them started on them? And then it's related to your point that, well, why do we need a prescription for something that's life-saving? So I really appreciate the discussion about this, and I think that policy is going to have to change. I haven't been in the trenches of opioid use disorders in the last 2 years or so, and a lot's changed since it seems like there's more discussion and a lot's changed since I was doing it. I'm hoping to get my program in Alamogordo to be doing more. We're not doing enough at this point, but I'm hoping to get that to happen.
I think there are a lot of people in the room here who will support you in doing that.
That's right.
Thank you. Thank you. Yeah.
I think the one thing about prescribing, though, is that it allows some tracking of buprenorphine, because when kids get into their parents' buprenorphine, their risk of total respiratory collapse is very high.
Right.
And so, and what we're seeing is particularly in the issue of diversion, that puts kids and families at very high risk. And so for us to know that a prescription's been written and who's theoretically is taking it becomes important.
It's a really good point, right? Totally safe, safer than aspirin in adolescents and adults. All opioids are dangerous in infants and toddlers.
Or when combined with massive doses of other CNS depressants, right, such as alcohol and benzos and all of those other things, then the risk profile changes dramatically.
Hi. Is it working? Oh, yeah. Philip, Mountain Center Harm Reduction in Rio Arriba County. I asked this question at another MAT presentation a little over a month ago, but if you had a patient who, for all practical purposes, was compliant, right? There were clean UAs or clear UAs and other things, and then you found out that that patient was injecting their Suboxone, would you still consider that patient compliant?
It's a great question. So I've had that. And so if they're injecting it, yes, and we have a talk about the dangers of injecting it. Because the injecting, especially like melted down, buprenorphine tablets or films, they usually don't dissolve completely, and we see a lot of thromboembolisms, and we see cellulitis associated with it. And so when I've been in that situation, we talk about it, and I try to discourage them from doing that. The other situation that comes up is, well, what if they're diverting? Right? So what if somebody is ostensibly doing well even, and their urines have no opioids in them, and you get a report or an admission or whatever that they are diverting, what to do? I can say what my personal practice is, and I'd love to hear other people's. What I do is I present them with the evidence, right, which could have just been a report. I don't try to get people to admit it or deny it. I think there's no utility in that. And I explain that I care about them, I want to continue to treat them, and we have to change the treatment plan, and that I'm going to stop buprenorphine for 3 months, and we have a talk about naltrexone. Want to treat you? What else do you need? Are you in groups? Do you need IOP? Do you need individual counseling? And in 3 months, we can revisit the topic. I don't say we'll restart it, right? Don't make that promise. We'll revisit the topic. I think it's really important to not ban people from any treatment for life. I think that idea really negates the whole idea that people are capable of change. And if we don't believe that, what are we doing anyway? So I think we should give people the opportunity to change and demonstrate that they're okay, and then revisit it, right? And I've been in that situation a number of times. And 3 months comes around and we have the conversation, right? But that's my approach. Other people's approach? How do you guys handle that diversion issue?
I mean, for us, it's really more than likely the mother who we're treating is diverting to her partner. And so we just basically invite the partner to come in and start treating them.
Nice.
So if we can treat both adults around the child and can reduce the risk for both of them, then that's probably a better solution. But that's in a fairly select population.
Yeah, at our clinic also, actually, because we have quite a bit of overlap with our patient population. So we've actually now made it a policy that if you have a partner who is using, because we often see the same thing, then we give them priority in terms of admission. We also are kind of fortunate, right? Because at our setting, we're also an OTP. So if we're seeing diversion, we're often just increasing the monitoring requirements. So we might require them to do observed dosing more regularly while continuing to engage them. Like, are there other needs that aren't being met, right? Are you diverting because you're trying to pay for your rent? And can we assist you with case management, things along those lines? So that's sort of how we wind up approaching it.
To get to your question from earlier, I actually think that in these situations where diversion is occurring, that is maybe a really good use case for subblockade, the month-long injectable, because I think it probably has 0 to almost 0 diversion potential.
That's right.
Hi, my name is Richard Kadomsky. I'm a resident physician at UNM. There was a lot of talk about the availability of Suboxone, and I think it would be a stretch in the near term to not need a prescription to obtain Suboxone, but I do think it's fair to say that the Suboxone waiver on a federal level represents an unacceptable barrier to expanding access to treatment. And I don't think the general population is aware of that, and I would try to encourage everyone to advocate for a change in policy on a federal level if you have that capacity. The other thing that struck me was this gentleman's question earlier about not having opioid replacement therapy available in jails, and I feel like that is sort of a morally egregious situation, especially in the age of mass incarceration when incarceration patterns and demographics are driven largely by structural racism. And in terms of shifting the policy around that, I think it's worth reminding policymakers for whom the most salient statistic is fatal overdose rates, that the most dangerous time, the highest risk for fatal overdose is when someone who is transitioning out of incarceration is not provided linkage to care and was not receiving opioid replacement therapy. They have probably the highest rate of overdose deaths.
Or naltrexone, I would say. I think we put them all together, but
excuse me, yeah.
Medication-assisted treatment. Absolutely. That week after you get out of jail or prison is an extremely dangerous week in terms of lethal overdose.
What is it, about 11 or 12 times higher? Is that right? 12? Right? Yeah. Thank you, Athena.
So earlier, Dr. Duhigg brought up a fairly common patient scenario that I see, and I'm sure many others see, where you have a patient with OUD in remission, but they just light up every month with their methamphetamine use. And in my annual visits, I address this, and what I found, I start to really kind of do some quick screening on whether they may have either been diagnosed with ADD, ADHD when they were young, or potentially have it. And it's just a rough estimate, but I think there could be anywhere between 10 and 25% as a modest estimate of individuals that actually self-medicate with methamphetamine because they're not treated with the simple, prescription equivalent of Adderall or something. And those that actually have gone in, ask their primary to do some basic screening and start on it, their meth goes away. So have you seen something similar?
I've seen high rates of methamphetamine use in people who have ADHD. The one study that I'm familiar with that looked at this, so it had people with methamphetamine use disorder and ADHD and treated them with like gold standard treatment of like a psychostimulant. In this case, I think it was either Dexedrine or Adderall. And it turns out that treatment did help their ADHD symptoms and had no effect on their use of methamphetamine. Neither increased it nor decreased it, which is nice. But so again, we're still waiting for that medicine that works for methamphetamine use disorder. But we do know that untreated ADHD significantly increases the rates of problematic substance use. So it's really important that we screen for it and that we treat it. And the evidence shows us that we can use psychostimulants in this population and not do harm. Now, I will only continue to prescribe a psychostimulant if they stop using the meth. So you got to test for both and do a test that shows meth versus prescription amphetamines, right, a confirmatory test. And then I stop the prescription if they use meth. And then again, I say I need a month worth of urine drug screens with no meth, and then we can start it again. I think that's all evidence-based and really helps them. It not only reduces, this increased chance of problematic substance use, but treating ADHD, so untreated ADHD is associated with so many bad outcomes, right? Unplanned pregnancies, sexually transmitted infections, more likely to be in a motor vehicle crash, more likely to be hit by a car as a pedestrian if you have untreated ADHD, right? You don't look both ways. So it's good for individuals and good for society. It's a great point.
No, the only thing I would say about that, Dr. Shaw, is that I think with the kids I take care of who often are coming from families with substance use disorder and family history of ADHD, what's hard to tell is whether there's ADHD or manifestations of PTSD. And so one of the things that I've been trying to do is screen more carefully for ADHD, but also trying to use either long-acting medication like Concerta so that they're not the peaks and valleys in levels, to keep dopamine systems stable, or to use a non-methylphenidate derivative, so like Strattera or guanfacine. And I found that if we carefully monitor that, we're getting pretty good results in terms of school completion or school performance by using atomexetine or guanfacine.
And finally, I know it's not published yet, but I know some of the groups out in New York are looking at kind of treating, what's the optimal medicine for this group with ADHD and stimulant use disorder. And I know what they're doing, and also in their clinical practice, that for people who are dependent on methamphetamine or have a meth use disorder, they're using methylphenidate formulations. And for people with cocaine use disorder, they're using like our Adderall and things like that. Not entirely evidence-based, but I think they're trying to gather some evidence. So hopefully we'll have more of a guidepost in the next couple of years to see what's the right medicine, what's the right dose, and what can we expect. But my clinical practice is identical, actually, to Dr. Duhig's with that.
And I'm just going to make a quick announcement, just to be respectful of people's time. About 1:45 we'll end. And I know there's a question there, and then Dr. Lindstrom will have closing remarks for folks. And if you need any other support, like I said, please reach out to us. There's a survey on your table, and there's pens. Please complete the survey before you go in a couple minutes. And then also there's note cards. So if there was a question you had that you want to put right on the note card and drop it if you didn't ask it tonight. And then, of course, you can email me. I'm on the New Mexico Opioid Hub website. It's Julie Salvador, jgsalvador@salud.unm.edu. And any of us that you got the email from, you can email that as well. So, Scott.
Hi, Scott, family and addiction medicine with First Choice Community Healthcare. Currently, if I'm considering as a provider writing an opioid prescription for a patient, and I'm required to, and I can look at their PDMP, prescription drug monitoring report for the state, and see that they're getting buprenorphine and getting treatment. This was alluded to a moment ago, that you cannot tell, and there is no report for that patient receiving methadone at their OTP or methadone maintenance clinic. That seems to be something that we could rectify on a state policy level. Should we be doing that?
That's a tough one, Scott. That's an excellent question, right? I mean, the spirit of the law is to prevent discrimination of these patients because of the stigma that exists. The patients who are, who are on methadone maintenance treatment or, agonist treatment in an OTP. But on the other hand, you're absolutely right? It compromises that continuity of care. I think in the law, the way it's written, the PDMP law, there is one requirement that provides some safeguard against it, and that's that if I'm the provider at an OTP, right, and I have a patient, I must check the PDMP at initiation of treatment and at least quarterly thereafter, right? So the OTP physician really should be doing that, getting the consents and, and contacting the providers to coordinate care. So that's built in, but then it brings up this bigger, I think, philosophical question. Like, what's better, right? And also, so for example, these are some of the internal discussions we've had at, even within UNM, right? Where people can sometimes see the diagnosis I have given in their diagnosis list, but they can't read my notes. What's better? Is that actually more stigmatizing? By reading my note, would they get a bigger, sort of a wider idea of who this person is, other than this person has opioid use disorder?
And that's a federal rule that prevents that.
That's a federal rule that prevents that, right? So it's a huge discussion, and I actually would lean towards, if I had to put down my money, or is that, I don't know the expression, but if that's the expression, I would actually be in favor of actually the methadone maintenance treatment showing up, because I think that empowers our primary care providers to provide better care.
Yeah, I think it's not because of a technicality. So the rule by the Board of Pharmacy is that pharmacies have to report, and OTPs are not pharmacies. I don't know if it's bigger than that.
Well, it's not a dispensed medicine. Similarly, we can't see if someone received opioids when they were on an inpatient treatment program. I think it's just the level of care and where it's being administered.
Yeah, but it'd be great. I mean, transparency would protect patients, I think.
My name is Charlotte Breeden. Not only am I a director of an OTP, but I'm also a pharmacist. And one area that I see as a problem is problem prescribers. As a pharmacist out in the community, we would always see certain prescribers who always prescribed large amounts. And despite the fact that we would report them to the Board of Pharmacy and DEA, I'd say on average, these prescribers would still be able to prescribe these opiates for years. And being in an OTP, we see problem prescribers from many of our patients. And we've asked the patients to stop seeing these individuals. So that's one area I think that hasn't been talked about that really needs to be addressed.
Yeah.
Totally. As someone who works in an OTP, I agree with you 100%, right? It's often the same prescribers we see, and our patients know who they are, and they will go to them. You know, when that happens, I think reporting is absolutely the appropriate thing, but then it takes and sometimes from just talking to some of the people who are working on this stuff from a law enforcement angle, sometimes it takes, sort of reports from multiple providers, right? And multiple reports to establish a pattern before they can, reliably do something. So I think it's all of our ethical responsibility if we think that someone is harming our patients to do something about it.
It's also where you report, right? So if it's a physician, that report should go to the Board of Medicine. If it's a nurse practitioner, to the Board of Nursing, et cetera. But it's really, it's not being a jerk. It's actually the requirement of having a profession. I love this definition of what a profession is. There are 3 parts to a profession. You have to have something unique that you do. You have to define standards, and you have to self-regulate. And we need to self-regulate. I've had this discussion with the medical board multiple times, and what they say is, we don't know who these people are unless somebody tells us. And we want to know who they are. And just because they're reported doesn't mean that you're ruining somebody's career, right? The medical board looks into it, or the Board of Nursing or other boards. They look into it, and if there's a problem, then there's a problem and it's addressed. But we either self-regulate or we will be regulated. I prefer self-regulation. So I think that takes us to the end of this, and we hand things over to Wayne.
Thank you so much. Let's have a round of applause for our presenters and panelists.